Hello and welcome to this video. This video is about the cytological diagnosis of lymphoma in serous fluid. Lymphoma refers to a type of cancer that begin in lymphatic system. Lymphoma develops when white blood cells called lymphocytes grow out of control. Pleural and peritoneal effusions are common in lymphoma. Meanwhile, pericardial effusions are rare. There are two main types of lymphoma: Hodgkin lymphoma and non-Hodgkin lymphoma. In Hodgkin lymphoma, cytological finding usually nonspecific. Diagnosis made through only on detection of Reed-Sternberg cells, while the other lymphomas previously referred as lymphosarcoma. Nowadays, these other lymphomas cases are now better understood. While nomenclature remain inconsistent, the pathologists are better equipped to interpret these other lymphomas using Kiel classification system. Kiel classification is a system categorizing non-Hodgkin in lymphoma, developed by Karl Lennart and Alfred Christian Feller. This system distinguishes between the high-grade and low-grade non-Hodgkin lymphomas and further subdivides into distinct entities. The Kiel classification system, developed in the 1960s by the Kiel Lymphoma Study Group in Germany, was historically used to classify non-Hodgkin lymphoma based on cellular morphology. As a morphology-based system, it categorized lymphomas based on the microscopic appearance of the cells, including cell size, nuclear shape and structure, cytoplasmic features, and the presence of nucleoli. The system divides lymphomas into two main categories: low-grade lymphoma and high-grade lymphoma. While the Kiel classification was highly influential at the time, it has been largely replaced by more comprehensive and modern classification systems, such as the Revised European American Lymphoma (REAL) classification, 1994, and the WHO classification of tumors of hematopoietic and lymphoid tissues. The materials required for the cytological diagnosis of lymphoma in serous effusions include samples of serous fluid obtained from body cavities, such as pleural fluid by thoracentesis, peritoneal fluid by paracentesis, and pericardial fluid by pericardiocentesis. The Papa-Nicolau (PAP) stain is widely used in cytology and plays an important role in diagnosing lymphoma in serous effusions. It enhances the visualization of cells in fluid samples, making it easier to identify abnormal or malignant cells, including lymphoma. The stain highlights key cellular structures such as the nucleus, cytoplasm, and nucleoli, helping to differentiate lymphoma cells from other cell types. The May-Grunwald-Giemsa (MGG) stain is particularly useful when distinguishing lymphoma cells from reactive lymphocytes or non-lymphoid tumor cells in serous effusions. It provides clear contrast between different cell populations, making it easier to identify lymphoma. The periodic acid Schiff (PAS) stain is a histochemical stain mainly used to detect polysaccharides like glycogen. While not the primary diagnostic tool for lymphoma, PAS staining can help differentiate lymphoma cells from carcinoma cells, as some lymphoma cells contain glycogen, which appears magenta or purple when stained. Next, let's talk about low-grade non-Hodgkin lymphoma. It is also called an indolent lymphoma. It has a slow growth rate and most often associated with B cells. Low-grade NHL can be classified into a few different types. The first type is lymphocytic lymphoma. In this lymphoma, the nucleus of the lymphocytes showcase abnormal characteristics such as high nucleocytoplasmic ratio, hyperchromatic nuclei, and coarse chromatin pattern. However, what's unique about lymphocytic lymphoma is that the chromatin clump together in such a way that it provide a clock face appearance. These cells with clumped chromatin in the nucleus is what's called cellules grumellae. Other than that, the cytoplasm is scanty, and the background may contain numerous lymphocytes and abundant red blood cells. Next, we have immunocytic lymphoma, which can be further divided into two. The first one is lymphoplasmacytoid lymphoma. The main characteristic of this disease can be indicated with the presence of numerous atypical lymphoplasmacytoid cells, or LP cells. LP cell can be easily distinguished by its eccentrically located nucleus. The abnormal characteristics exhibited by the cells includes high nucleocytoplasmic ratio, pleomorphism, irregular nuclear membrane, and coarse chromatin pattern. As for the cytoplasm, it is typically abundant with pale blue in color. Another type of immunocytic lymphoma is plasmacytoma. This disease can be characterized by the presence of abnormal myeloma cells. The abnormal myeloma cells often exhibit characteristics such as high nucleocytoplasmic ratio, pleomorphism, and irregular nuclear membrane. Other than that, multinucleation and presence of intranuclear inclusions, known as Dutcher bodies, can also be observed in some cases. As for the cytoplasm, it is abundant, and cytoplasmic inclusions, such as Russell bodies, may also be present. Centroblastic charged centrocytic lymphoma is a mixture of the centrocytes and centroblasts. It's commonly caused by follicular lymphoma. Follicular lymphoma is a type of blood cancer that starts in the lymph nodes. There are 3 grades of follicular lymphoma. Grade 1 and 2 are low grades, and grade 3 is a high grade. The characteristic of centroblastic centrocytic lymphoma is high nuclear cytoplasmic ratio, condensed nuclear chromatin, inconspicuous nucleoli for centrocytes, nuclear shape irregular or cleaved. Cytoplasm is scanty for centrocytes and abundant cytoplasm for centroblasts. These characteristics can be found in centroblastic centrocytic lymphoma. For centrocytic lymphoma, centrocytes lymphoma is more anaplastic than centroblastic centrocytic lymphoma. The size of the cells that dominate the fields is small to medium. The characteristics that can be found are nuclei shape irregular or cleaved, coarse chromatin, inconspicuous nucleoli, and scanty cytoplasm. Now let's move on to high-grade non-Hodgkin lymphoma, also known as the aggressive type since it rapidly grows and come with poor prognosis. Classified based on 3 morphology: centroblastic, lymphoblastic, and immunoblastic. Now, centroblastic and immunoblastic are categorized under diffuse large B-cell lymphoma, DLBCL, except for lymphoblastic since it can arise either from B or T cell. It can arrive as de novo or results of transformation of low-grade non-Hodgkin lymphoma. For example, this is the end stage of chronic low-grade of centrocytic centroblastic type. This is a common subtype that has better prognosis than others. The predominant cell is obviously neoplastic centroblast and may contain small lymphoid cell, such as neoplastic centrocytes. Next is based on lymphoblastic from non-T or B cell. This malignant lymphoma behaves very similarly to acute lymphoblastic leukemia, ALL. It mainly contains small lymphoma cells with the characteristic of irregular shape, folded or clefted nucleus, dense chromatin, scanty cytoplasm, and may has nucleoli. Some cells become necrotic despite no treatment were given. The result for periodic acid shift is negative. If the cells are larger with coarser chromatin and has prominent nucleoli or resembling immunocyte immunoblast, the differential diagnosis can be B-cell neoplasm of intermediate type. Lymphoblastic from T-cell, almost similar with B-cell lymphoblastic. The lymphoblast is admixed with abundant lymphocytes, macrophages, mesothelial cell, and neutrophil. Some cases contain scattered eosinophils. Some cell also undergoes phagocytosis. When stained with acid phosphatase, it gives strong positive signal. And now for the 3rd type of malignant lymphoma, beta immunoblastic. It is a malignant disorder of the B cells that can occur in immunosuppressed patients. Only 9 cases recorded in this category, however. The cytological findings varies. 2 of these effusions presented normal cells with no neoplastic cells recognized. The remaining 7 cases all had recognizable malignant cells. Neoplastic immunoblasts in the above cases had certain features in common as follows. Firstly, they all have large nucleoli, large pale Golgi area at the cell center, and basophilic cytoplasm, which is maybe full of fat granules. Other than that, its malignant cell resembles immature plasma cells, with it well-developed cytoplasm. The result of periodic acid shift stain was variable, sometimes negative, but in some cases quite strongly granular positive. Most cells measure around 15 to 22 millimeters in diameter. One of the special case, majority of the cells are dead. We can see few surviving lymphoma cells among abundant necrotic ones. This appearance is very characteristic of high-grade lymphoma. Other than malignant lymphoma, malignant histiocytosis also occurred, which is a rare and aggressive cancer that involves the abnormal accumulation of histiocytes, and it most commonly affects the lymph nodes. On the later stage develops purpura. Diagnostic features that presented are foamy cytoplasm, multiple irregular nucleoli, and also we can see recognizable leukocyte. The result of PASS is always positive. I'll be discussing the differentiation between benign lymphoid cells and lymphoma in serous effusions, an important aspect for diagnosing and staging lymphoma effectively. Firstly, cytological examination involves examining effusion smears under a microscope. Here, lymphomas are identified based on their distinct morphological features. Next is immunocytochemistry, ICC, which helps confirm the type of lymphoma, whether it's B cell or T cell, by detecting specific markers like CD20, CD3, or CD30. Then flow cytometry allows real-time analysis of cell surface and intracellular proteins. This technique distinguishes between benign polyclonal cells and malignant monoclonal lymphoma cells. We also utilize cytogenetics testing, which involves chromosomal analysis to detect abnormalities, such as clonal chromosomal changes indicative of lymphoma. Finally, molecular studies focus on identifying gene rearrangements or translocations, which are genetic markers associated with lymphoma. Together, these advanced diagnostic tools provide a comprehensive approach to accurately identify and differentiate between reactive benign cells and malignant lymphoma cells. Next part is how to distinguish between lymphoma, carcinoma, and other neoplasm. Firstly, main cancer in body fluid comes from epithelial cancer, and the cell usually stick together, but lymphoma cells do not adhere to each other. Second point, usually carcinoma cell has small round nucleoli and mucus secretion, but lymphoma cells has several uneven nucleoli and also do not have mucus secretion. Lastly, for other neoplasm, such as sarcoma, usually can be distinguished by diagnosis based on patient history. However, for melanoma cases usually mistaken as lymphoma, its cell has a distinct large nucleolus. To conclude this video, a diagnosis of lymphoma in serous fluid based solely on cytology is insufficient, though it can provide a provisional assessment of lymphoma grade and differentiation. It requires careful evaluation of cell morphology and immunophenotyping. Although challenging due to the often subtle and variable presentation of lymphoma cells, techniques like flow cytometry and molecular studies can aid in confirming the diagnosis. Timely and accurate identification of lymphoma in serous fluid is crucial for proper treatment planning and prognosis. We hope you all learned something from this video. Thanks for watching.